Greetings and welcome to Counseling Women with Multiple Sclerosis in Middle Age and the Postmenopausal Years. At this time, all participants are in a listen-only mode. If you have not already done so, please close all of the programs on your computer. You may submit a question via the web at any time by using the Ask a Question feature on the left side of your screen. If anyone should require operator or technical assistance during the conference, please press *0 on your telephone keypad. It is now my pleasure to introduce Amy Perrin-Ross. Thank you. Please begin.
Thank you, Roya. Welcome, everybody. Thank you for joining us this evening for our webcast, Counseling Women with Multiple Sclerosis in Middle Age and the Postmenopausal Years. This program is jointly sponsored by the Consortium of Multiple Sclerosis Centers, the CMSC, and the Delaware Media Group. It is generously supported by educational grants from Celgene and Sanofi Genzyme. As Roya said, I'm Amy Perrin-Ross. I am an advanced practice nurse and neuroscience program coordinator at Loyola University Medical Center, the MS Center in Maywood, Illinois. I am joined by two distinguished faculty panelists. The first is Dr. Maria Hutchins, Associate Professor, Department of Neurology, Howard Medical School, and she is the Director of Women's Health Program at the Sighorn and Women's Hospital in Boston, Massachusetts. And our other faculty presenter tonight is Marie Moore. Marie is a nurse practitioner at the Neurosciences Institute, the Carolinas Multiple Sclerosis Center in Charlotte, North Carolina. So the webinar tonight is accredited for continuing education by the Consortium of Multiple Sclerosis Centers, and you can see each of our disclosures listed right up front. We move on to the three learning objectives that we have for this evening, the first of which is to discuss health issues affecting women with MS as they transition through peri- and postmenopausal stages. Secondly, we're going to attempt to analyze the pros and cons of continuing disease-modifying therapy in older patients and those with secondary progressive MS. And then thirdly, we're going to look at adapting MS patient care and counseling approaches to meet the changing needs of an aging female population with multiple sclerosis. So we're going to start off talking about how do the changing priorities of postmenopausal women affect MS care. As we know, many of these women no longer have young families. They may still have children in their teens and perhaps even older at home, but they're not dealing with young babies generally. These women most often have a desire to very much stay active and independent as they age. Now, some of them may be retiring or cutting back on work related more to aging issues and needs in the workforce, perhaps, than their MS, but nonetheless, those two may be intertwined. And women in the postmenopausal areas often are nearing secondary progressive MS or are already affected by symptom progression. So at this point, I'm going to turn the discussion over to Marie Moore to talk about who are our patients with MS.
Thanks, Amy. So with MS, we typically talk about patients being diagnosed between the ages of 20 and 40, striking during the prime of a person's life. But we see the full lifespan of patients living with MS when we walk into our clinics. And in fact, more than half of the women that we will be seeing are postmenopausal. We know that there are 3 to 4 women diagnosed for every 1 male diagnosed, so we see significantly more women than men. A quarter of the people with MS are adults over the age of 60. And we also know that people with MS are surviving to older ages. They're not living as long as the general population, roughly about 7 years less, but they're still living much longer. Those survival data have really improved with time. So in 1993, the Consortium of Multiple Sclerosis Centers created a registry for persons living with MS, and this registry is a voluntary endeavor, and it collects a wide range of self-reported health-related information from participants twice a year. So we're going to look at a few of the clinical characteristics from data reported in 2015 that surveyed roughly 8,000 patients. To the left of the screen, we see that the mean age that the patients were at the time of the survey, at their symptom onset, at their time of diagnosis, and roughly how long they had had the disease. To the right of the screen, we take a closer look at this group, and it's not surprising that the majority of patients were female. It's also not surprising that of those taking DMTs, far more relapsing patients were on a medication versus secondary progressive patients. But I think some of the other data begins to get a little interesting. Despite really very similar educational backgrounds, we see far fewer of the patients with progressive disease were still employed full-time versus relapsing MS patients. And with that, we know that employment provides people with daily structure and interaction. So when patients exit the workforce, we certainly see big transitions occurring in their lives. This study also showed us that patients that identified as having secondary progressive disease were more likely to have moderate to severe disability. Once again, these patients are having to deal with a lot of challenges that they obviously or I would say most likely weren't planning to have to deal with. We also see that a lot of these patients were on Social Security disability, which also probably tells us that they may have some financial stressors occurring. So I think as we look at this and kind of interpret some of this data, we can come to the conclusion that there are a lot of challenges that these patients are facing. So as priorities change with older women, we know that people with MS are living longer, they are staying active longer, and a lot of this is because the overall health care and effective use of disease-modifying therapies has changed how our patients are doing. We know that life stage transitions are usually associated with changing needs and priorities, as I was just alluding to. These occur regardless of if a person has a chronic disease or if they're relatively healthy, though I would say that they are more likely to be challenges in those with chronic disease. But as healthcare providers, I think it's really easy for us to focus on the disease and disregard some of these other health concerns. You know, we can look at the fact that as these lifestyle transitions are occurring, we lose, again, some of the daily structure employment provides. Patients are likely not as physically active. We can see physical deconditioning. Likely they're not as socially engaged or cognitively engaged. We can see challenges there. We can also see that many people associate their jobs with their identification, who they are. So we can also see the likelihood of depression and other issues occurring. So there are a lot of different things that we really need to be talking to our patients about so that we can identify where those needs and challenges are that we may be able to intervene and help with.
So, Marie, you brought up a couple of really good points, and I think if I take the opportunity to move back here to slide number 7, looking at the mean age at diagnosis, 38 and 40 for relapsing remitting MS and secondary progressive MS. I think those numbers are quite interesting. I think many of us who work in large MS centers or see quite a number of MS patients think that many of these people are diagnosed much younger, but this is a survey of over 8,000 people, and I think certainly that is telling us something about the population that we're seeing and perhaps still delay in terms of the time to diagnosis. Also, looking at life stage transitions. You know, I saw a patient in the clinic yesterday who was just diagnosed with MS. She's about 11 weeks postpartum after her first baby, and she's very confused about what are symptoms of MS, what might be related to her postpartum status. And again, if you've never had a baby and this is your first one, you don't know what your postpartum scenario is going to be like. The same thing is true with women going through menopause. They've never been through it before, so they really don't know how they are going to respond in terms of their own hormones and the kinds of things that they may experience, things like flushing, hot flashes, and some of those kinds of things. So I think those transitions are important for us to keep in mind, and helping our patients understand that not everything that they're experiencing is necessarily MS-related. As you said, we often tend to disregard other health issues. We're focused so intently on MS, but we really have to help our patients see that there's potentially a balance there. Hence the reason that in my clinical arena, I'm extremely insistent on every patient, male or female, having a primary care provider so that that person can help manage everything that actually isn't MS. So we'll move now into the impact of changing hormonal patterns on MS disease trajectory. We'll look at the influence of changing estrogen, progesterone levels in women with MS, and the effects of MS, or the effects of menopause on MS symptoms and progression. So I'll turn it over to Dr. Hutchins for this discussion.
Thank you very much, Amy. It was a pleasure to participate in this webinar and share some of our thoughts with everyone on this very important subject. So when we think of the influence of sex hormones in women in general on disease susceptibility and disease changes over the span of multiple sclerosis diagnosis, we do realize that there are substantial differences that must have something to do with sex steroids, with hormones. We don't always understand the exact mechanisms of the interplay between hormones and immune system. But clearly, the female-to-male ratio, which is much higher for women for autoimmunity in general, for most diseases, including MS, the increased predisposition after puberty, that male-to-female change really first occurs after puberty's transition, after a pubertal transition. The data that we have related to pregnancy and disease stability in pregnancy and worsening postpartum, all of these various stages that clearly have something to do with hormonal changes are very important for us as neurologists to understand. And menopause is certainly one of these types of changes. So there's some information on the fact that high levels of particular female sex hormones, especially the estriol, which is the hormone of pregnancy, the estrogen of pregnancy, as well as male sex steroids for males, might have beneficial effects on CNS in people with multiple sclerosis. And the theory is that the sex steroids tend to shift the immune response from Th1 response, which is traditionally considered to be a pro-inflammatory, to a Th2 response, which is an anti-inflammatory response, as a general immune system setting, if you will. We know that in pregnancy, for example, the Th2 response predominates, and then after delivery, postpartum, which can be associated with high risk of relapses, then the shift again occurs from the Th2 to Th1. So this could be important. We don't know whether estrogen or progesterone exerts specific anti-inflammatory or neuroprotective effects in patients. Everything that I just mentioned, we know to be true from various clinical trials and studies that have been taking place for, upwards of 2 decades now. But we still are not exactly sure as to the mechanism of these effects. We don't understand why and how the sex hormones exert their oftentimes beneficial effects on the MS course. We know that menopause can bring with it a changed symptomatology for our patients. Some symptoms clearly get worse, and some symptoms substantially overlap between multiple sclerosis and menopause and are essentially the same. Hormonal therapy in form of oral replacement therapy or even intravaginal preparations for some of our patients can at times alleviate certain symptoms. For example, intravaginal preparations are good and sometimes helpful with sexual dysfunction, vaginal dryness, sometimes even bladder infections, those types of things. And then the hormone replacement therapy has its own beneficial effects that have been reported generally in some populations, perhaps not specifically or conclusively in multiple sclerosis patients. We at our center have spent some time looking at the effects of menopause on multiple sclerosis, on the actual disease. It's not an easy thing to study. So we have a long-standing data collection program in MS patients called CLIMB. It's been in place for over 15 years now and has many thousands of patients. Information is prospectively collected, and certainly a lot can be inferred from studying and analyzing the wealth of information that we have available to us. So we do know that gonadal hormones modulate onset and course of multiple sclerosis. We do know, as was mentioned earlier here just a few minutes back, that menopausal transition, especially if early or iatrogenic or surgical, appears to be increasing the risk of cognitive decline in MS patients, as well as in general population, actually. We know that the studies that followed MS, women with MS prospectively through menopausal transition did show significant worsening of EDSS after menopause, and that study adjusts for various other comparisons and confounders. And so it does appear that having gone through transition is an independent predictor of worsening of EDSS for female patients. All of this is suggestive of the opportunity that we can take and use and regard as a window for studying effects of hormones on the course and outcome in multiple sclerosis patients. So another study that colleagues of mine were instrumental in completing had to do with the effects of menopause and multiple sclerosis, and that one was based on the online cohort of, I believe, on the basis of patients like me. So this was a questionnaire study. 513 respondents were analyzed, of which 55% were women postmenopausal transition. Half of those patients reported induced menopause, so meaning that the menopause occurred prior to its natural time, most likely because of the treatments or because of surgical interventions. The median age of natural menopause is 51. It was determined that surgical menopause in this cohort was associated with more HRT use. The postmenopausal state, surgical menopause, and earlier age at menopause were all associated with worse MS rating scale scores. And again, these were adjusted for age, disease type, and duration, and so multiple confounders were accounted for. And again, it does appear in this cohort, as well as in the CLIMB cohort that I showed you in the previous slide, that menopausal transition is an independent predictor of EDSS-related worsening in multiple sclerosis. What do we know about clinical trials in sex hormones in MS. So it's not a simple question. So there are certainly points that can be made in favor of those clinical trials and also against. The points to be made in favor of clinical trials include, as we discussed, that estrogens potentially have anti-inflammatory effects, especially the estrogen receptor alpha stimulation, and perhaps neuroprotective effects in estrogen receptor beta stimulation. In phase 2 trials, estriol was studied and was found to independently reduce enhancing lesions upwards of 70% when compared to placebo while on treatment. And then once the treatment was discontinued, then the lesions unfortunately returned. Cognitive improvement was observed with estriol treatment versus placebo in patients with equal baseline disability. So that's also an exciting outcome. And then progesterone treatment in very early phase clinical trials have been suggested maybe to help facilitate remyelination. Now this is a little bit out there, and I would take it with a grain of salt. It certainly has not been proven, and I wouldn't put my patients on progesterone based on just this one sort of unsubstantiated issue here. Arguments against using estrogens as specific treatments to be studied for phase 3 clinical trials, as indicated on the slide, are as follows. There is certainly insufficient and inconsistent efficacy data so far from early phase clinical trials. The trials cost a lot of money. Some of them take many, many years to be completed, and it's not clear that that this treatment, even if it were found to be extraordinarily successful, that it would actually be safe or applicable to all of our patients, right? So we can't treat our male patients with, estriol hormones, for example. We probably can't treat anybody for very extended periods of time with these types of medications because of potentially increased risk of malignancies and other complications. If we look at all the patients that have been exposed in clinical trials to sex steroids, it's quite limited. The data is quite limited when we look at it in terms of patient years. And in order for us to be able to detect significant adverse outcomes, we certainly need higher numbers of early phase clinical trials before we move on to phase 3. Sex-specific hormonal treatments would have limited therapeutic applicability, as I've mentioned, and that's, in my mind, a most significant dilemma concerning expanding of this therapeutic option to a wide variety of patients. Then there was a nurses' health study where female participants were examined with a diagnosis of multiple sclerosis, and a physical functioning assessment was done between 3 to 10 years after the final menstrual period. So to remind everybody, the menopause is considered to be final when a year goes by without a menstrual period. It's typically after that time that an OBGYN or a family practitioner or perhaps even a neurologist would measure FSH and estrogen levels, and then would inform the patient that in fact they're now in the complete menopause state. The study assessed association between hormonal therapy use and this particular physical functioning assessment scale. It was determined that patients who, in fact, did receive hormonal replacement scored higher. In this case, higher is better. That means that they were more functional, they were doing better than those patients who were not treated. So again, something to keep in mind. It doesn't mean that this is a fabulous option for every single patient of yours, but for some select type of patient, it certainly can be considered and discussed. I think, Amy, back to you now.
Yes, thank you, Dr. Hutchins. I think if we look back at slide 14, one thing that stands out to me with the premenopausal women, the wide error margins there in terms of their physical functioning. And it would be interesting to take a deeper look at this data to see what, if anything, might have caused this error bar to be so significantly larger than either of the postmenopausal or the premenopausal who have never actually used hormone replacement therapy. I just wonder if there may be something to that that could help guide us as practitioners in terms of looking at supporting hormonal replacement therapy. So we'll transition now to the continuation of disease-modifying therapy, do we or don't we? That's always a topic for discussion with all of our patients, premenopausal, postmenopausal, or whatever. So we're going to look at some consideration for the continuations of disease-modifying therapy, review some of the current data as well as the controversies, and then talk about discussing patient preferences that we may see in clinical practice. So for this discussion, again, I'll turn it over to Dr. Hutchins.
Thank you again, Amy. So let's chat a little bit about what do we know about stopping disease-modifying therapy. We all are faced with this question seeing patients in clinic, every clinic we have. We certainly all have patients who've been on an injectable or at this point already on an oral med for years upon years, and they appear to be very stable, and they're getting older, and there's this general perception that perhaps for some of these patients, trying to discontinue disease-modifying therapy would be a good thing. So until recently, we had very few studies to reference when we pondered that question that would directly assess continuing versus discontinuing disease-modifying therapy in comparable populations. And so we would have to go by, a gestalt, a feeling that we'd have about a particular patient. So this changed a bit over the last literally 2 to 3 years. We now have a few studies that looked into this question more directly, and this is what we learned. So in terms of published literature, so there was a fairly recent publication only a year ago looking at this question. So what happens when the disease-modifying therapy is stopped in older patients? So do we continue or do we discontinue? So if we think that we should continue the treatment, we have something to rely upon, some data. We do know that relapses occur even in older patients. About 30% perhaps of patients who are older would have relapses if left untreated. We really cannot predict who will have post-DMT relapses. It could be a little bit like a coin flip, right? So they could, or they might, or they might not. And on each individual patient case basis, we don't know. We can't really counsel them effectively about that. We don't know whether stopping DMT has detrimental effect on subsequent disease course. And then there is an old saying, if it ain't broke, right? So if things are going well and somebody's taking their particular treatment and are doing very well, why do we need to stop? There could be an economic consideration of why do we need to stop, but in terms of clinical consideration, they're tolerating it well, no side effects, might continue. If we, on the other hand, think that we should discontinue treatment, we also have something to consider. So we don't know whether treatments that we have work in patients who don't have active disease. In fact, recently, even those medications that are approved for primary progressive disease really appear to work primarily in those patients who have some evidence of disease activity, either clinically or by MRI scan. And if they have no evidence of disease activity clinically or by the MRI scan, the treatments don't seem to be nearly as effective. We have very few available data on DMTs in older patients. We have really a thought that benefit to risk ratio of DMTs might in fact decrease as relapse rates decline with age. What we could tolerate in a younger patient with active immune system and inflammatory disease, we might, in terms of side effects, we might no longer be willing to tolerate in an older patient with more, subdued, if you will, immune system, and with potentially higher risk of those side effects, such as infections and others. And then we have, on that same subject, we have few data on long-term safety in older patients. So do we know anything about what are the predictors of relapse and disability progression in MS patients who actually discontinue treatment? And this is a study that was done with the MS base by Dr. Kissler and his group in New York City. They assessed almost 5,000 patients, majority of whom were females, from 20 MS-based centers. They had, you can see here on the slide that a majority of medications that were discontinued were interferons, there was some GA, and single digits natalizumab and fingolimod. So annualized relapse rate post-discontinuation was 0.22. Clinical disease progression rate, 8.23 per 100-person years. Patients with secondary progressive MS with EDSS greater than 6, or those who've not had any relapses for greater than a year, had the lowest chance of relapse after stopping treatment. Younger patients with moderate disability, so less than 6, had the highest risk of relapse after stopping. And then what was interesting and unexpected from this study, I thought, was that patients with secondary progressive MS or severely impaired at baseline had the highest risk of disability progression after stopping treatment. So now we're not talking about relapses, we're not talking about inflammatory changes, we're talking about disability progression in patients who are more severely impaired after the treatment was discontinued. This was, to me, most interesting and unexpected finding of this study. So then we asked ourselves, are stable MS patients who stop DMT then become at higher risk or get to be at higher risk for relapse and disability progression specifically because of stopping treatment? This is a study that looked at, there was a point X at which time the treatment was discontinued, and then the patient was followed for a median of 4.85 years, and the observations are reported here. You can see it both on the Kaplan-Meier curve on the right and also described on the left here. So 36% of those who stopped disease-modifying treatments experienced a clinician-reported relapse within the next 5 years. About 30% of those who stopped had a sustained 3-month disability progression. 13% of those who stopped had both a relapse and a confirmed disability progression. And then almost half of those who stopped resumed their DMT. I don't know, actually, looking at this slide, whether they resumed the same DMT or changed, but they resumed some form of treatment after approximately 2.2 years after stopping. So they felt significantly worse, or their doctor thought that they looked significantly worse to warrant restart of therapy in about just under half of the cases, which is also very telling. And so then there is another ongoing study, which is called DISCO MS trial. And the question here is, can people in later stages of MS stop taking disease-modifying treatments? We don't have results yet. This is a randomized controlled trial that is looking at adults with MS of 55 years and older and who have not had a relapse or MRI changes in 5 years now, but have experienced disease progression and as a result had discontinued treatment with disease-modifying therapy. The outcomes are either MS relapse or a new brain MRI lesion as a primary outcome, and a secondary one is, of course, a change in disability progression, and it's also assessing various quality of life metrics and reported outcomes. And the study is supposed to end in 2023, so we should have something 4 years from now. This is a very important trial that I'm looking forward to learning about more. And I think back to Amy, I believe.
Thank you. Before I turn thank you, Dr. Hutchins. Before I turn the presentation over to Marie for this brief case study, I'd just like to mention that that the dilemma is always there. Do we stop? When do we stop? What are the pros and the cons of stopping and continuing? And one of the things I try to remember to point out to my patients is that when stopping a DMT, we're not just looking for the kinds of inflammatory relapses they had 20 years ago when their MS first started, but we're going to be monitoring things such as the invisible symptoms, particularly things like cognitive symptoms, cognitive decline. And again, if we intertwine that with menopause, it can be very difficult to tease out. But I also remind them of the importance of continuing to do follow-up MRIs, even though they're not on a disease-modifying therapy, because we're going to be looking for things like atrophy that's aggressive and/or increased T2 lesion burden that we may see. And I think I agree with you definitely. Looking forward to the PCORI study on do we stop, and if we do, what happens to it. So at this point, I'd like to turn it over to Marie for a brief discussion about the continuation of DMT for a woman in her 60s. Marie?
Thanks, Amy. I think you both have set this up perfectly. This is such an interesting conversation and a very highly individual discussion with any patient we're having this conversation with. So this case presentation is about Barbara, who is a 60-year-old female who's had MS since her mid-30s. Her disease was active intermittently over the years with incomplete recovery from some exacerbations. So that tells us that she has definitely got some disability. Her initial therapy was glutaramine acetate. She was accepted into a clinical trial for ocrelizumab and is elected to remain on this treatment. Barbara is currently using a cane for ambulation, so I would estimate her EDSS to be a 6 roughly. And at a scheduled visit to the clinic, we are going to plan to discuss considerations for her to continue on ocrelizumab, switch to another DMT, or discontinue. So I'd really like to open this discussion up a little bit. I'll start by saying when I'm seeing a patient like this, one of the very first the first two things I want to know is, number one, if the patient is bringing forward the request to make a switch, why is that? What are their concerns? But number two, I really want to know what their disease has been like recently as well as in the past. What does the most recent MRI show us? What are we seeing on clinical exam? And how does the patient feel their health is from an MS perspective overall? So that's really where I start this conversation. Amy and Dr. Houchins, I'll let you guys kind of bring in some other points that you guys would like to share with this case presentation.
Dr. Hutchins?
So I think we've done a good job, sort of as you said, setting the stage and addressing this question. Again, this is something we see quite a lot in clinic. Whether would I keep this patient on ocrelizumab? If you remember in the trial, the people who didn't respond well to this drug, at least in the primary progressive arm of the not arm but primary progressive trials with ocrelizumab, were middle-aged women. So it's not necessarily, so we don't get a sense that this is a primary progressive patient. It looks like this is a relapsing patient, at least started that way, and now she is, perhaps getting worse. She's in a Ocrevus, or was in a Ocrevus trial. It's not clear whether we have data to suggest that Ocrevus works in secondary progressive MS. We are not learning here that she's had recent relapses, so we really kind of get a sense that this is a secondary progressive patient. So the question is, do we continue after the trial is over, or do we tell her that there's really no data to suggest that she remains on the treatment? I think at this point, despite everything we just talked about, it's still very much a judgment call.
Absolutely.
If she's generally vigorous and healthy and doesn't have a lot of bladder infections and is tolerating things well in general, I would probably keep her on eculizumab for another year or two, especially if you get a sense that she's sort of getting worse. But I would be very honest with her and tell her that we currently don't really have the data to support that decision. But I would probably keep her on for a couple more years and then reassess.
So I agree with what both of you have said, and I think the one thing that I would also talk to her about are other comorbidities or potential comorbidities. Does she have a strong family history, for example, of breast cancer? Does she have a strong family history for cardiac disease? That would help inform me about if we were to switch, what might we switch to? And again, I would have to agree with Dr. Hutchins. I probably would not recommend switching right now unless this was something that she brought up, and I would have all of those discussions with her. So moving on, we should look at how do we talk to our patients about aging with MS, looking at the things we've mentioned: cognition, comorbidities, wellness, and the effect of disease on aging brain volume. And we'll turn this back over to Dr. Hutchins.
So thank you very much again. So we're going to talk a little bit about what happens to our brains as we get older. This is a sobering couple of slides for all of us. The truth of the matter is that as we age, we lose a bit of brain volume every year. It's measurable, and it had been measured. And our patients are in worse shape than we are because they lose it more quickly. So there is a reason that a lot of newer trials, newer DMT trials, use or look at brain atrophy as a secondary or tertiary outcome measures. And we as providers look at that data, trying to decide between otherwise seemingly appearing meds in terms of efficacy. Sometimes we make that decision based on the atrophy data, especially if our patient has sort of more of a cognitive problem and sort of functioning problem, more so than physical. We want to know what atrophy is, what happens with brain atrophy on a particular treatment. In older patients, atrophy is the major driver of disability progression, especially the gray matter atrophy. We've known that thalamic atrophy correlates very well with cognitive impairment. We've known that for some time. We now are able to, with the 7T scanners, we're able to quantify the degree of that atrophy. We're also able to look at cortical atrophy and other gray matter structures, and such as caudate, nucleus, and other areas, and correlate those more carefully and more closely with specific types of cognitive impairment that our patients experience. We also know that not only cognitive impairment is related to a brain atrophy, but also EDSS, the physical disability. EDSS is, of course, the scale that's driven much more by physical than cognitive disability, and that is also driven by, is associated with, I should say, brain atrophy and gray matter atrophy specifically. With all that in mind, when you look at patient X, when you look at Barbara, for example, from the previous case, or any other individual patient, we're not able to reliably quantify an individual patient brain atrophy and use that metric to assess or predict clinical response or clinical progression, for example, for that individual patient, or a response that individual patient might have differentially to treatment A or treatment B. We're not quite there yet. What are some of the effects of the disease on aging in general? So early in the talk, we mentioned life expectancy. So patients with MS are living certainly a lot longer than they used to, 20, 30, 40 years back, but the life expectancy is somewhat declined or decreased in MS. And also the age-related decline in physical and cognitive function in our patients is accelerated by, a decade or two, and that's still very significant despite all the medications that we currently have. Having MS is independently associated with a lower functioning score, the SPF10 that we mentioned earlier, and that's independent of age. women with progressive MS scored substantially lower versus women with relapsing MS on a variety of metrics, but specifically on the PF10 score. And then women with MS declined faster in midlife and in those who were aged greater than 50. So here on the left side, you see specific, from the Nurses' Health Study now, you see specific symptoms and issues that patients reported in women in mid-50s, from mid-50s to early 90s really, reported as to how their life was affected because of multiple sclerosis. I believe that the next slide is presented by one of my colleagues here.
Yes, we'll turn it back to Marie. Thank you, Dr. Hutchins.
Of course.
Sure. So next we're just going to talk a bit about comorbidities and the effect that they have on aging. The first thing that we'll mention is just that there's a lifetime prevalence of depression in MS patients of about 50%, which is about 3 times higher than that of the general population. But probably the most important point to make about that is that depression is treatable. For anyone who's worked with MS long, we all know just how pervasive the effects of depression can be on every aspect of MS care. So this is one of those points that cannot be overstressed. But I think the next point that is a really good one to make is that comorbidities increase with normal aging, right? So hypertension, hyperlipidemia, diabetes, ischemic heart disease, chronic lung disease, we see these all in the general population. The challenge with our MS patients, though, is that these comorbidities appear to increase disability progression. They have a negative impact on health-related quality of life. They increase risk of hospitalizations, increased risk of mortality. So that burden of the comorbidity tends to increase at a time in patients' lives when disability is also worsening. So the management of that MS is increasingly complex. And Amy mentioned at the beginning of this how much she stresses the importance of primary care providers to our patients, and I would echo that. I've been a nurse practitioner for 19 years and have not ever worked in a practice in which we had the ability to provide primary care to our patients. So this has really been a huge part of care, is to make sure patients appreciate and understand how these things impact their MS care and how important it is that they are seeing their primary care provider for management of all of these different things. Every time I see a patient, as part of the normal kind of questions to ask, I usually try to ask, have you had any new diagnoses since you were here last? I also go through and just get a feel for example, if they're diabetic, how have your sugars been? How well controlled is that? I want to get a feel for how their overall health is, because I know the impact that that's going to have on their overall well-being from an MS perspective. When we talk about wellness and looking at that, this was a study that a Canadian study of around 700 patients over the age of 55 who had MS for at least 20 years. And as would be expected, there were far more women than men. But what the study was aiming to look at was whether there were sex differences contributing to patients' perceived health. And I thought this was really interesting. What they found was that although older women were just as likely as men to retire early due to MS, women continue to participate in household work and social opportunities more often than older men. And this participation in social interactions seemed to somewhat mitigate the impact of depressive symptoms on the health-related quality of life in females versus males. So I think what that really tells us, as we're having these conversations with patients and as we're really talking about the comorbidities, we should also really be talking to them about lifestyle and asking them, how active are you? What are you doing? And really encouraging them to maintain independence to the degree that they're able to do so. I talk about exercise with patients all the time, as I'm sure my colleagues do, and really stress the importance of that. And I think, patients need to understand that even something small can make a big difference. A normal part of aging is to lose muscle, and so I really want to encourage patients to do anything they can to maintain muscle mass and to maintain especially core strength, which can really help with preventing falls, et cetera. But the findings of this study really support the concept that women aging with MS are more resilient, and I think that that's one of those things that we can really have in our back pocket and really kind of let patients know and encourage them to really be advocates for themselves and to really be active participants in their own care. Kind of one of the final points we really want to make, too, with this whole topic of aging is just that it's also important that we are initiating conversations about long-term planning with our patients. These data are kind of old, but what at the time of these data in 2010, at the time of this article, about 60% of nursing home residents with MS were less than 60 years old. Again, I hope that that's changing. I feel like that probably is based on my clinical practice, but regardless, we certainly see patients who are quite young who are in nursing homes because their disease has just been so disabling. I think it is also probably more consistent that we're going to see quite a few patients with MS who do have at least some sort or some form of activity limitation in which they're going to need help. We're going to need to make sure that patients are safe and that they've got the appropriate assistive devices and help within the home to avoid falls and to avoid hurting themselves. And about a quarter of our patients are going to need long-term care services. So we need to keep all of that in mind as we're seeing patients and make sure that we're asking the questions and delving into kind of their home environment and making sure they're safe. In regards to long-term care planning, the MS Society has excellent resources that can really help patients. It's important that we're giving patients the phone number for them to get a hold of a navigator to really self-advocate and find out what resources are available and what resources may work for them should the time and the need occur. We want to make sure that we're encouraging our patients to plan for advanced MS and increasing care needs, especially in those who've had the disability progression that would suggest that that's going to potentially be a part of their care. And I think probably the most important point that this slide is making is that palliative care does not mean end-of-life care. Our palliative care colleagues are absolute godsends to our patients, and really palliative care is that approach that it helps improve quality of life through prevention and relief of suffering by means of early identification and assessment of needs. And so they can really introduce a lot of tools and a lot of support within an environment to prevent injury and unnecessary suffering. So I think these things are just something we need to be keeping in our mind and mindful to discuss with our patients. Amy, I'm going to turn it back over to you.
Wonderful. Thanks, Marie. So, and Dr. Hutchins for your wonderful ideas. I'm just going to move past that last case study to give us an opportunity to answer some of the many questions that have come in and yet be respectful of your time. So as Roya said in the beginning, to ask a question, you're going to have to ask it in the managed Q&A box. We're not taking questions via the phone. And so what I'd like to do is address the first question, perhaps to Dr. Hutchins, which is, has significant cognitive decline been observed in women late 40s versus minimal physical decline?
That's an excellent question. So, in fact, we've just now looked at a cohort of patients from our center, what we call primary cognitive MS. So it's very rare. Okay, so it's probably on the order of 1 to 2% of patients who really have dramatic cognitive impairment above and beyond the physical disability. So MS can cause, somewhat, relatively mild, sometimes moderate cognitive impairment, especially earlier in the disease, oftentimes getting worse as we discussed later in the disease. But it's not very common, and certainly not in the women in the 40s as opposed to men, to see dramatic cognitive impairment in the setting of minimal physical disability. So that's not what we've typically observed. I'm happy to, have my colleagues chime in here, but that would be my perception.
Yeah, I have to agree with you in terms of, the things that we're seeing. If we had very rapid or significant cognitive decline with the absence of any physical decline, I think I might be looking for other causes, maybe metabolic causes for, an acute decline in cognitive function. I'm going to take our last question and address it to Marie. Would you recommend stopping disease-modifying therapy in stable patients with relapsing remitting MS at age 60?
So as a blanket statement, I would say no. I'll be honest, in my practice, we like to wait a little bit longer to even really have this conversation. I think we've just seen far too many patients still active at this age. But as we really alluded to, this is such a complex question, and so many variables are at play when having this conversation with patients. But, if somebody gets to their mid-60s and they have just been stable for quite some time, and, we've not seen any reason to absolutely keep them on therapy, we'll definitely have the conversation. But I will say that this is something that we never do without putting a plan in place of how we're going to monitor them post discontinuing the therapy. So there is going to be, office visit about 3 months after they're off, 6 months after they're off therapy, with an MRI at least within that year. So we're definitely watching these patients closely. We're also strongly encouraging them to call us if they have any changes. So again, this is a very interesting question, and it's one that I hope we have, as Dr. Houchins presented earlier, a whole lot more information on in the coming years. But like I said, as a blanket statement, I would say no, I would not recommend that.
Okay, thank you both so much for your excellent insights and thoughts and presentations tonight. This concludes the webinar, Counseling Women with Multiple Sclerosis in Middle Age and the Postmenopausal Years.